Next talk is on management of failed trabeculectomy by Dr. Bindu. Over to you, ma'am.
Thank you, Manju, for the opportunity. Now, when we do a trab, and what we dream of is a ideal bleb which is diffuse with a good height, a vascular and microcyst. But not always we encounter this. We do encounter angry looking blebs or a low height bleb, or it is a cystic bleb, or you get a flat fibrous bleb with vascular or a flat bleb. So, not to worry much, because the incidence subconjunctival and episcleral fibrosis 20% in early stage and 30 to 40% in the late post-op, and subtenon's encapsulation is 10 to 20%. So now we'll just see how we fight to convert this failure to success. So before understanding this, we have to understand the stage of healing so that we can intervene accordingly. So in the initial stage, you have to identify failure. That is the first and foremost thing. The signs are the hyperemia, the excessive vascularization, increased intraocular pressure, and during the months and weeks, it comes to small bleb, an encapsulated bleb with a ring of steel, a vascular cystic bleb to a flat bleb in the late stage. So when we are planning for surgery, we have to consider the predisposing factor, like when a patient is on a maximum eye drops, a patient with neovascular glaucoma, uveitis, aphakia, and a history of prior surgery and eye syndrome are prone to go for failure. So now we have a failed bleb, and how to intervene depends on the stage of where we identify the failure. So it starts with the surgery itself, where you need to have a bloodless field. Try to be less traumatic as possible with blunt dissection and proper hemostasis. And during the early stage, there is a lot of inflammation going on, and that time you upregulate the steroids, and we just follow it up. So the first and foremost is to identify whether the ostium is patent. Do a gonioscopy and identify if the ostium is patent. If not, you have to address that issue first by either YAG laser or surgical intervention. And then, as I mentioned, preoperatively, we have to give steroids if it is a high risk case and it's going for failure, and minimal trauma during surgery. And the other major factor is we have to use the modulators like the mitomycin. Earlier we used to use the sponges. Now we are more into injections, which give a precise quantity of the drug into about 7 millimeters away from the limbus, and you diffuse it posteriorly. You don't have to fear of leaving around the sponges, and you have a more uniform spread of mitomycin. And then during surgery, when you pre-place releasable suture, it gives you an advantage to titrate the pressures in the post-operative period. Initially, we used to do it from the corneal end, and you have the loose sutures coming out and producing the windshield wiper. Now, if you start it from the scleral end, you have a loop there which does not come out easily, and you can remove it when necessary. So the interventions when we are doing it before an organized fibrosis is within 2 to 3 weeks. Initially we go for a bleb massage, and then we can do this laser suture lysis or release the releasable sutures, and also we have the 5FU injections. So initially when you do a digital massage, it is not doing it. You have to assess how much pressure is needed to bring about the drainage. That gives you an assessment of how much fibrosis is happening there, and which area is the bleb is forming, because it gives you an idea of which suture to release first. Just see the bleb forming when you're doing a digital massage. And then you can remove this releasable sutures from the slit lamp. If the bleb is flat like this, just remove this. You just pull it towards the lower end, and should be in the same line of sutures. And then after that, you can do a massage and see the bleb forming. Or you can opt for suture lysis with the special lenses, but there is always a risk of conjunctival buttonholing and subconjunctival hemorrhage, which again can lead to fibrosis. The 5 few injections, they have a more localized effect, a shorter half-life and a fewer complication. It can be used in a congested bleb. You can start it in the second week with a dose of 5 milligrams subconjunctively weekly. So if you have a high IOP post-trab in the earlier period when the osteum is patent, within a week you do a bleb massage. I'm not able to see it here. Okay. Within 1 to 4 weeks, you do the releasable suture. And if it is a cystic bleb in the early stage, you do conservative management with ocular massage, give aquasuppressants and increase the steroids. But if it is not settling, then we'll have to go and do the needling. Here you can see the mouse. This is the ring of steel which is preventing the blood from flowing backwards. So you use either a 26 gauge needle or 30 gauge needle. First you inject a local so you get the plane and then go and break the fibrous bands. So once you have done it, you can give an injection, either 5FU or mitomycin after that, away from the bleb. So this is the post-kneading bleb. Now your bleb is well formed. Sometimes on a flat bleb, we'll have to go into the subscleral plane, under the scleral flap, and then do the needling. In the late stage, when it is a flat bleb, you can do the needling under the flap itself. This is how you revive the bleb. The complications when you do needling are the SA hemorrhage, needle tract leak and conjunctival buttonholing. It can cause hyphema and if too much, choroidal effusion and hypotonia is also complications which you can encounter. So when you have done the needling and again it goes into failure, you have no other option but go for a repeat trap. And if some cases like the silicone oil going and causing fibrosis and failure of the bleb, you will have to resort to the tubes, glaucoma drainage devices. To summarize, primary prevention, preoperative steroids and stop anticoagulants. Intraoperatively, optimal cautery, application of mitomycin in a more diffuse and posterior way. Postoperatively, look for signs of failure, titrate the topical and systemic steroids and do laser suture lysis or remove the releasable sutures. Digital massage. If the iris is an osteum, pilocarpine, YAG laser and repositioning. Needling with subconjunctival or subscleral with 5FU or mitomycin. And if this fails, go in for a revision surgery for a repeat trap or a tube. So the first to 6 weeks is the most crucial. You have to identify and act appropriately and then you can revive the bleb. Thank you.
Thank you, ma'am. Thank you for explaining the management of failing bleb with a video.